Hello everyone, this is DrBarai. Welcome to this another episode of podcast. In this episode, we are going to talk about ultrasound artifacts. Now, who is the best person to talk about ultrasound artifact than Martin Necas? You have probably seen many of his educational videos or conferences or courses. In this particular episode, Martin is going to tell us ins and outs of ultrasound artifact. Martin has an illustrious career as a sonographer and an educator. Martin is affiliated with the University of Otago in New Zealand. He is also the chief sonographer in Hamilton in North Island of New Zealand. We have so much to learn from Martin. It's a great privilege to have Martin with us. Let's delve into this wonderful world of ultrasound artifacts with Martin Necas. Welcome, Martin, to this podcast show, and thank you for taking your time. We look forward to it.
I am so excited. This is going to be a great opportunity. I can't wait to get started. Amazing.
So, Martin, we are going to talk about the ultrasound artifacts. Thank you for sharing all your expertise. And I thought that we'll keep it nice and crispy and brief. So this is what I was planning to do. At first, we'll talk about a bit of introduction, what is the ultrasound artifact. And then we'll talk about the common different types of ultrasound artifacts. We will give a lot of examples from your huge collection of images and clips. We are also going to talk about what are the clinical implications of these ultrasound artifacts. At the end of it, we'll share some of your tips and tricks on how to manage these artifacts. So once again, thanks for joining us, Martin. So please talk us through what is the ultrasound artifact for our audience?
Absolutely. So I think the easiest way of thinking about ultrasound artifacts is that artifacts are appearances on the ultrasound image that seem perfectly real to the ultrasound system, but they do not represent the reality of what's happening inside the patient. And that there are many causes for artifacts to arise, and they're usually because the assumptions about the behavior of ultrasound inside the patient have somehow been breached. It may be for acoustic reasons or for technical reasons and for other reasons. So it is really the responsibility of the operator to determine whether the image represents reality or whether it's an artifact. And we'll have a look at some strategies on how you can decide that. So there are many assumptions that the ultrasound machine must make about how sound is propagating and interacting with the human tissues. One is that sound travels in a straight line and that echoes return along that straight line. That's not always the same. We have the assumption that speed of sound is constant, but we actually know it varies about 10% across different tissues. Tissues that are stiffer are faster, tissues that are more elastic are slower. Another assumption is that the attenuation rate, the loss of intensity, is gradual and it's predictable. However, that is not the case. There may be many situations where tissues attenuate more or less, depending on pathology or even just normal anatomy. The assumption that attenuation is obvious to the operator and it's correctly compensated by the operator or the system is also frequently breached. And that perhaps the two comparable tissue reflectors of similar location will generate similar echo is definitely not true. Ultrasound is, for example, angle dependent. So the same echo at certain locations will look different depending on angle of insonation. There are, of course, many other assumptions that can be breached. For example, that the beam dimensions are small in height, width, and thickness is not true. Our axial resolution is very good, lateral resolution worse, and elevational or slice thickness quite poor. We have many other assumptions. For example, that echoes originate only from the central beam axis, not always true. We have side lobe artifacts. That each reflector only generates one echo is not the case with mirror images, for example. The assumption that the arriving echo has been generated by the last emitted pulse is breached in a range ambiguity artifact. The assumption, we have another one, that the rate of image acquisition is so fast that it exceeds physiologic events is sometimes not correct, so there may be motion artifacts. And of course, we often assume that the operator, that is the user, you and I, or people in the field, are using the system appropriately. We want to use the system appropriately, but sometimes we can make technical errors that lead to artifacts. And then, of course, our ability to control the system, use good acoustic windows, as well as appropriately adjust system controls may have been breached.
So it's like almost like an illusion or hallucination, you can say, that there is something not there, but we can see it, or the machine can probably think that something is there, but actually it is not there. That is
absolutely
that is the artifact. Yeah.
Absolutely. And in other ways, you could say that, the machine, as sophisticated as it really is a dumb instrument. It cannot distinguish whether an echo is real or not. It's really up to us if we are responsible. And we also rely on all the components of the system, the transducers, the cabling, the receiver, to work in synchrony and work optimally. There can be electronic artifacts, even with modern ultrasound systems.
Absolutely. So that brings up to the next question: that whose fault is it? Always it is someone else's fault. So would it be how do you differentiate it?
Absolutely. So there are many things that are responsible for formation of artifacts. Acoustics, the behavior of ultrasound in the human tissue, is partly responsible in that the interaction can be predictable most of the time, but can lead to unpredictable events. For example, beam deflecting in unexpected direction. And of course, the system always assumes that everything is happening perfectly. So there is a breach of that assumption. There's another category, and that is a system artifact, where the system components may be lacking sensitivity, or there's an issue with hardware processing, or maybe part of the system is broken, such as a dead element in a transducer. And I think the biggest one, and one that we need to be most aware of, is the operator. That is really us, our awareness and recognition and taking corrective steps when we see artifacts is perhaps the most important thing, because once again, the ultrasound machine itself is an instrument that cannot do it for us. It's our job to do.
Exactly. Thank you for that fantastic explanation. And I think the most important thing with artifact would be to be aware that there may be some artifact, and we need to interpret it accordingly so that we can get the right diagnosis.
Absolutely. And you're right, the diagnosis is key, because whilst many artifacts are just a nuisance, sometimes an artifact can actually lead to an appearance that's so misleading, it can simulate pathology.
Absolutely. So a little bit of ultrasound physics for our viewers. And as we can see here, that we have got the ultrasound is like a sound, which is going like compression and decompression or rarefaction. And that goes in such a high speed that we cannot see it, but the machine can identify it. Now, there are some basic principles of the ultrasound artifact, but before that, we need to understand a few basic principles of the ultrasound itself. So tell us, Martin, a little bit about these few things like absorption.
Sure. So absorption really is perhaps described in another term, also known as attenuation. And absorption or attenuation pertains to the loss of the intensity of the ultrasound signal as it propagates in the human body. And in fact, the loss of signal intensity is quite catastrophic, and it's particularly catastrophic at certain object interfaces. So, for example, we might have a highly absorptive structure, such as a gallstone in the field of view.
Yes.
And this gallstone may absorb so much ultrasound energy that very little, if any, penetrates beyond the object. And this will then result in a black band beyond that object, where the sound is attenuated, or there was complete loss of visualization. So, for example, a shadowing artifact is a very good example of where sound has been absorbed. It can also be reflected, not necessarily absorbed. Some objects absorb, some reflect, some also scatter. I saw that you have a
Yes, there is a
graphic
scattering.
on scattering. Yeah. So all of these are components of attenuation, weakening of the ultrasound beam. So absorption or attenuation, scattering, and reflection cause loss of beam intensity. This example that you're showing now, refraction, is a process whereby the ultrasound beam bends. And that tends to happen due to interaction with a non-perpendicular interface where there's differences in propagation speed. It's akin to a famous sort of high school experiment that many of us would have done, dropping a pencil into a glass of water and then viewing it from an angle, and the pencil appears bent. That's
Yes.
refraction, optical
Mm.
refraction. And in sound, it happens exactly the same.
Excellent. Thank you. Now, there are hundreds of different types of common artifacts. And in fact, you have got a book on the artifacts, and there are, I think, about 100 artifacts there. So tell us a little bit, what are the different common artifacts you would like us to be aware of?
Oh gosh, you have nicely expanded the section here, but I guess you can sort of group artifacts into artifacts that are due to attenuation, due to refraction, due to beam width artifact. And one of the fundamental ones actually that you're showing on the screen now is acoustic speckle, whereby if you look at the ultrasound images, they're not smooth, they're composed of small dots of information. And so this gives texture to organs. For example, your liver or kidney have this characteristic peppery texture. Acoustic speckle really is an artifact where the dots are. There is really no actual echo information. It arises from the constructive interference of tiny wavelets of sound as they return back to the transducer. And in the past, where machines used to use straight lines of sight to image a patient, such as in the graphic on the left, this kind of speckle artifact or appearance was very pronounced. More recently, in the last 15, 20 years, manufacturers have come up with a special compounding technique where the beams are not emitted into the patient in a straight line, but at a wide variety of angles. And this tends to reduce the appearance of speckle because the speckle pattern is different depending on the angle at which we look at the same object. And this tends to smooth the images and makes them a lot smoother in texture, and objects within tissue are much more conspicuous. So this is a good example, actually. This is probably a thyroid nodule that we're imaging with the spatial compounding off. It's a very salt and pepper texture, quite a harsh image. Whereas with spatial compounding on, not only is the image smoother, but the boundaries are better defined and the conspicuity of the lesion is much better. And so for most ultrasound applications, spatial compounding should be on.
Amazing.
Thank you. Even the handheld device or the portable devices that we use in our point of care ultrasound, we have got these techniques available, and that gives so beautiful image quality, but that decreases those speckle artifacts.
Absolutely. Most machines do this now very happily. And without it, you really ultrasound looks terrible without spatial compounding.
Yes.
So it's incorporated into almost every system available now.
So tell me, sometimes to get some sort of diagnostic ultrasound, we actually need to keep it turned off to get the speckle artifacts. Is there any situation that speckle artifacts actually helpful for diagnosis of certain conditions?
So it's interesting you bring that up because, in fact, there are specific circumstances where the detailed texture that's not contaminated by smoothing is actually advantageous, but there are actually very, very few of those. One good example is in breast imaging, where the visualization of microcalcifications is a little bit better with spatial compounding turned off. The other thing is that spatial compounding tends to be able to see beyond shadowing structures. So it doesn't really have to do with speckles so much as spatial compounding reduces attenuation artifacts like shadowing. So if you want to see shadow behind the structure, turning it off is a good idea. Otherwise, the beams looking from different angles can penetrate underneath the causative structure, like a gallstone or kidney stone, making it hard to appreciate that there is attenuation there.
Thank you. I saw a few instances where the small stone in the vesiculated junction in the bladder wall, sometimes I cannot see it if that acoustic speckles are off. That means the spatial compounding is off.
Yeah.
And this type of artifact, attenuation artifacts, as we were talking about earlier, that is very common, and we see this all the time. So please talk us through about the attenuation artifacts.
Absolutely. I think these are some of the most commonly known artifacts, Savijit, and they really are separated into two big groups. Either attenuation of a structure is very low, in which case the beam just penetrates through easily and the intensity of the beam beyond the structure is greater than expected, such as in this image of the gallbladder, where there's a wide band beyond the gallbladder due to its low attenuation compared to the surrounding liver. Or, of course, the opposite can happen, where there is increased attenuation and then there's shadowing. So with acoustic enhancement, where the attenuation is low, one of the things that I want the viewers to remember is, whilst lower attenuation is often associated with fluid, and so sometimes people think that, oh, acoustic enhancement is associated with fluid. That's not necessarily the case. Yes, it might be the case with the cyst that you see on the left image, or an abscess which is fluid filled. However, you can also have so you can also have acoustic enhancement associated with solid structures, such as a liver tumor, which is embedded in a fibrotic or cirrhotic liver. So we cannot assume that acoustic enhancement is related to fluid only. It's only related to a lower attenuation rate.
Exactly. That's a very important point, that acoustic enhancement not necessarily mean that this is always fluid. And as we were talking about acoustic shadowing, this is an example. Please talk us through.
Yes, so acoustic shadowing is exactly the opposite. So with acoustic shadowing, we have increased attenuation rates. So there is loss of visualization beyond the causative structure. It can be complete shadowing, such as you're seeing a rib pass through the field of view in the video clip, or it can be partial or dirty shadowing, where there's only partial obstruction of the beam due to things like bowel or highly attenuating structures. So total shadowing you do get with structures that either completely absorb or completely reflect sounds. These are good examples: gallstones, calcifications, fetal bones, in case of obstetric ultrasound, calcific plaque that we see on Doppler imaging, causing nice stripes of dark shadowing. That's total shadowing, yes.
And when there is total, there should be some partial as well.
Of course, you can have partial shadowing in structures that only partly absorb the ultrasound, but not completely, or partly reflect the ultrasound. There are many examples. It's a nice view of a intrauterine contraceptive device. You can still see beyond the device, but you can see the image is darker there. You can have attenuating tumors, such as this germ cell tumor of a testicle, or the attenuation may not be related to pathology. It may be related to acoustic window. So, for example, in transverse of the liver, if part of the transducer is resting too much on the sternum, then you can have a partial shadowing artifact from that. Bowel is another common structure causing partial shadowing.
Excellent. Thank you. And you talked about dirty shadowing as well.
Yes, so dirty shadowing and partial shadowing probably are the same thing. Dirty shadowing is often described in association with bowel gas. So there can be actually a combination of artifacts there. There can be some reverberation, some shadowing, sometimes even a ring down, and the combination in the literature sometimes is referred to as dirty shadowing because it's non-uniform. So hence the term dirty.
Yes, perfect. Thank you. And that brings up to the interesting topic of Venetian blind shadowing, which looks like a Venetian blind on the right-hand side of the screen.
Yes, so sometimes you may have tissue with um, heterogeneous characteristics where there is areas of shadowing due to pathology and then normal tissue immediately adjacent, and this pattern can repeat. So if we see this, for example, with uterine adenomyosis, where there is multiple black shadows ringing down from there, and that's really related to the presence of fibrosis as well as endometrial glands within the myometrium. It causes that repetitive pattern of shadowing and enhancement. Sometimes you can see it with subcutaneous edema as well. There's a nice image here where partly it is attenuating, partly it is enhancing, and it's causing this a nice regular stripy appearance.
That looks beautiful.
And
similar to that is the edge shadowing, Martin.
Yes, so edge shadowing is a specific sort of shadowing. It is due to attenuation, but it's not really attenuation due to absorption or reflection. It's attenuation due to a combination of critical angle and refraction that occurs at the very extremes of round structures, whether they are fluid filled like varices or solid, such as the thyroid nodule metastasis. It's due to the sound either reflecting or bending away at the very edge of the interface. So that is always related to edges, often round edges, hence the term edge shadowing.
Thank you. So I try to illustrate it here. So this object and this object, they have got different attenuation. And so at the edge, there is this shadowing. And this always expands distally, isn't it?
It does if you're using a curvilinear transducer because of the fan-shaped nature of the image. It does not if you're using a linear array, and that has to do with the shape of the scan lines.
Thank you. The next twist is getting a little bit complicated now is the beam dimension artifacts. Martin, your favorite topic?
It is. It's actually quite a complex topic, but it's not difficult to understand. I think what I like to relate it to is how ultrasound is different to, for example, CT scanning. On a CT image, a pixel of information is very uniform. It's like a sugar cube. So CT is a isovolumetric imaging technique in that the same object viewed from different angles will tend to produce very similar appearance and similar dimensions. Ultrasound is very much not like that. The pixel of information on the ultrasound display is very narrow up and down. It means we have good axial resolution, but it's quite wide. We have poor lateral resolution that's mainly affected by focusing. And the ultrasound image is also quite thick. That's the elevational resolution. The in-plane lateral resolution is affected by your user adjustable focus. The thickness of the image is related to the transducer design because along the transducer surface, there is a lens that focuses the thickness of the plane and tries to limit the thickness of the slice. But the thicknesses are still considerable, and you might have had experience placing a needle into a small vein or trying to drain a small collection. The needle appears like it's inside the object, but you're not drawing any blood or fluid, and the needle is in fact resting in the wall of the object on either side of the plane of the imaging, but it looks like it's in the center of the image. So these are some of the considerations that lead to beam dimension artifacts from the fact that there are resolution limits in these 3 dimensions.
And there are a few examples that you can
Absolutely. Yeah, there are many examples we can look at. So for example, in the image on the left where we're imaging a ovarian cyst, it is a transvaginal image. You can see that the pixels on top of the image are quite densely spaced. There is very good lateral resolution. But as we go down the image, the pixels become more and more smeared until we get to the very bottom of the image, and the information is almost absent there. And that is because The lateral resolution is best at the point of focus, which in this case, the operator would have put the focal point where they're looking at the small hemorrhagic cyst. And so beyond the focal point, the beam is widening and the information becomes smeared. The echoes are much broader, representing the greater beam width of the transducer. And of course, beam width is a big problem when we try to assess very small structures, whether it is could be small vessels in the emergency room setting where you're trying to cannulate someone. Or it could be looking at fetal heart when we assess for cardiac anomalies. Any small structure will only be well represented if we have correspondingly high resolution. And as you know, with ultrasound, things are never ideal. Our patients also are getting larger and larger to add to the challenge. So we might not be able to resolve structures clearly due to a combination of poor resolution and just attenuation. We can't use high frequency transducers. A nice example actually is this the 3D ultrasound on the right hand side where we have two little embryos. They look like jelly babies. I mean, they're not jelly babies. These are well-formed embryos. Perhaps it's something like 10, 11 weeks. But the ultrasound lacks sufficient resolution to represent the bodies correctly. And that's due to beam dimension problems.
That's a great example.
Yeah. Now, this is a great point, actually, where because axial resolution is always your best resolution, when we're trying to resolve small structures, vessels, ducts, nuchal translucency, something very, very small, it's best to orientate the image so that we're taking advantage of axial resolution. That is, the structure should be perpendicular to the beam or parallel to the transducer. These are two examples of measurements of a bile duct. The bile duct is not at all visualized if it's sloping at a diagonal angle through the field of view, but it's beautifully visualized in the same patient if the beam is directed at 90 degrees. And this is due to beam width considerations. Your beam is always smallest in the axial dimension.
Yes, I think in case of the common bile duct measurement, I find it really difficult to see it unless it is exactly at 90 degrees.
Absolutely. And there will be worse if the bile duct is small, and it'll be worse if it's deep, and it will be worse if the system that you have at hand is not a high-end system. So all of these considerations actually make things worse and compound together.
So
Now,
how
what
can you
can we
reduce
do?
that beam width?
Exactly. So we would love to have thin beams, of course, and manufacturers have gone to great lengths to try to achieve this, but ultimately it is frequency related. The higher the frequency, the smaller the beam width, and so using high frequency transducer is the key. Tissue harmonic imaging also has the effect of reducing beam width. It's a very complex topic as to how it does that. I think for your viewers, it's important that they know that it does. And interestingly, reducing the power and gain can also reduce the beam width. And that's because if you are operating at high power and high gain, the pixels on the screen literally glow. You can do a simple experiment by dropping a pin in a glass of water and turning the gain up and down to visualize the object. You'll see that it changes size. And so keeping gain and power at a conservative level is really useful. In this example here, we've got a cluster of small gallstones on the left, and you can't really see any acoustic shadowing. That leads to diagnostic ambiguity. Maybe this is just sludge. Whereas if a high frequency transducer is used, which has a narrower beam width, you can see discrete shadows there. And so it can be really useful to reach for a higher frequency transducer when you need the detail.
Excellent. So on this beautiful example, on one side, we are reducing the beam width, but on the other hand, we are increasing another artifact, which is a shadow artifact.
Exactly. And the reduction of the beam width means that we are better targeting the gallstones, and they're more likely going to obstruct the narrower beam and cause shadowing. So if you need shadowing to confirm that these are gallstones, consider using a higher frequency transducer, sometimes actually a ridiculously high frequency, like a linear array transducer. That's exactly what's being used in this example.
Mm,
Yeah, so you might be able to get away with it just to get the finer detail.
excellent. Yes.
Mm. Now, I'm not sure how many viewers that will be watching this will ever perform fetal heart studies, but it's such a lovely example, so thank you for including it, because these are two images of the same fetal heart from the same angle in the same patient,
Mm,
virtually within a few seconds apart. And you
mm,
can see the left one is taken with a 5C1, so low frequency curvilinear transducer, kind of your mainstay transducer, and the other one is with a linear array transducer. And the difference in image quality is astonishing. So I
mm,
would like to remind everyone that the principle of how we use transducers should always be highest frequency as long as you can get away with it. And
yes.
that's, of course, attenuation related. Yeah.
Excellent examples. And that also brings us to the next topic of slice thickness and
Mm.
how can it affect the artifacts?
Absolutely. So slice thickness for those of you, of course, who have ever cannulated a patient, particularly in longitudinal section, will have experienced this problem.
Mm,
The ultrasound has a finite thickness of the beam. It's not a infinitely thin slice of the anatomy. And so there's potential for structures from behind and in front of the ultrasound beam to be sandwiched into that one section. The image on the left shows a carotid artery where there is an apparent occlusion. However, a transverse section in the image in the center shows that it's not occluded. The vessel has good patency, but there is plaque along the wall, and so that plaque is projected into the center of the vessel due to bad beam width. Yeah.
mm,
And actually, the slice thickness artifact also is problematic when we look at gallstones, particularly once they're in the common bile duct, because people often want to see a shadow associated with a small stone in the duct, but we're just too deep. The slice thickness is too great, and a small object there will almost never shadow. So.
mm.
There we have to really rely on more of the imaging appearance and our clinical judgment to determine that there's likely a stone in the duct.
Thank you. And this is
Oh,
another
this is
good
a good one.
example.
Yes, yeah, this is a good one. This is actually completely normal vein. It's just changing direction, probably because there's a tributary coming into the wider section.
Mm,
But the smaller section of the vein looks like it's echo-filled, and you might think that it's thrombosed or occluded. It's in fact perfectly patent. It's just so small
mm,
that the beam width is wider, and some of the fatty tissue from behind and in front is projected into the vein and causing contamination and basically making it full of echoes. Where the vein is wider,
mm.
the diameter of the vein exceeds that of the slice thickness, and then you can visualize the vein clearly. So the larger the object, the less it is prone to slice thickness artifact.
Yeah, I think in clinical practice, for example, in the emergency department, we see this all the time. In a difficult patient who needs ultrasound-guided IV access, it can be quite difficult to identify the
Absolutely.
veins. And especially with this slice
Absolutely.
thickness, it becomes harder.
Absolutely. Yeah.
So, Martin,
Now,
talk us through about the side lobe artifacts, which is
yeah, so
quite tricky as well.
it is a tricky one. So we think of an ultrasound beam as a kind of a beam of light where we're looking into the patient. It's not quite like that.
Mm,
This beam of light has other beams surrounding it. They're much weaker, but they're always present. It's impossible to eliminate them. So around the central beam, we have other accessory beams called side lobes. And there's potential for an object to be picked up by the side lobe. The echo then returns to the transducer, and the machine misregisters this echo as believing to have come from the center of the field of view.
mm,
So these artifacts typically cause broad lateral streaking in the image, such as you see in this echocardiogram. They're usually broad sweeping artifacts. It can be associated with all sorts of bright structures. It's usually something very bright. In this case, it's the pleural a pleural air interface beyond the heart that is causing that. So side lobe artifacts, remember, due to a structure that's highly echogenic, picked up by this accessory beam, and it's projected into the main beam simply because the machine doesn't know that this echo has come from somewhere else.
And this is giving us some hallucination. Like, for example, this gallbladder, it's giving us some hallucination. Something is there inside the lumen, but actually this is just a misinterpretation by the machine because of the side lobe artifact.
Yeah, absolutely. You could mistake this for fluid level in the gallbladder, for example.
Yes.
An easy way of getting around it is to simply try from a different angle. A real structure will always be there, whereas this artifact will be quite angle dependent.
Exactly. And there are some good examples here.
Oh gosh, there's many. Yes. So we got a fetal head that's got a nice spread of white echoes around it. That's side lobe artifact. Foley catheters, they are highly reflective, so they also will tend to have these whiskers of artifact coming from them. The side lobe artifact is not only in the plane of imaging, but also it's circumferential around the beam. So sometimes you can have a side lobe from a structure that's not even in the field of view, such as the image you're showing now. And there are many others. You see this in echocardiography all the time, particularly in echo, because echo is prone to artifacts anyway due to the difficulty in getting good acoustic access.
So one of these, another common type of artifact is refraction artifact, Martin.
Yes, we've already kind of briefly mentioned what refraction is, and that is basically the bending of the ultrasound beam. Now, a lot of the time when the ultrasound beam bends, you don't even see it because there may be change in the image projection, but it's uniformly projected to one side. There are, however, very unique circumstances where there may be duplication, triplication of an object, or distortion of an object related to refraction. And that's particularly in the midline, as you're showing here, where the two rectus abdominis muscles are highly refractive structures because it's a dense muscular structure with a high propagation speed embedded in fat, that's low propagation speed. And there can be bending of the ultrasound beam causing duplication artifact. It's actually quite easy to simulate this at home if you have two round glasses of water and you place them on a bench and put a ping pong ball behind them and look at them from a certain distance. That ping pong ball will be doubled. You will see one in each glass, and this is due to refraction. So you can simulate this optically, and of course we can see it acoustically. So where we have an acoustic lens, particularly two of them, rectus abdominis muscle, then you can get duplication of the object, such as here with duplication of the SMA. And this duplicate can affect other things. Yes, of course. So not only can you duplicate the SMA, but anything along the midline can be duplicated. For example, you can see duplicate yolk sacs, duplicate gestational sacs, duplicate or triplicate Foley catheters. So if this is happening, to confirm whether what you're seeing is real or not, the best thing to do is to slide to one side, either right or left, and get away from the causative structure, which is the rectus abdominis muscle. If you just scan through one of the muscles, refraction does not cause duplication.
In my practice, Martin, sometimes instead of doing the static image, I usually prefer clips. And that during that time, I can move it and I can see actually if there's any difference. Because I find that if you do a static image, then always this artifact can come. But if you move it, then that might disappear. How do you feel about that?
Absolutely. And in fact, recording video clips is so much better than static images because, you know, at 20 frames per second, which is quite modest, and we sometimes work with much higher frames, within, say, 3 seconds, you know, you have 60 frames of information instead of just one. So I think we certainly encourage our staff as well, particularly when there's something ambiguous or something a little bit tricky, to take a video clip because it's much better to review. This is a nice example, actually, of a real-time video clip of refraction causing duplication of the hepatic veins. You can actually see the shimmering pattern. It's because the acquisition is relatively slow with spatial compounding. And I can't tell you which object is the real one. Either or, to the machine, both are real, but you of course know that there's only one set of hepatic veins.
Yes, perfect. And similar reverberation artifact, we see this quite often with the foreign bodies, with the needle. I try to illustrate it here. Tell us about the reverberation artifact, Martin.
So reverberation artifact is one of the more common artifacts, and it's easier to understand. Basically, it arises due to a sound beam being trapped between two parallel interfaces. And then as the sound cycles up and down between these interfaces, it produces an echo each time it hits the interface. So to the machine, it looks like the echoes are arriving from a deeper and deeper structure because, of course, the way that the machine interprets depth is from the echo arrival time. And this then causes horizontal banding on the image. It can be large bands, it can be small, it can be regional. So there are many varieties as illustrated in these examples. It's usually the case that reverberation arises from the body wall. That's by far the biggest offender. And it's because the body wall is a sandwich of tissues. You have skin, subcutaneous tissue, ligaments within subcutaneous tissue, deep fascia, muscle, other fascial planes, and so there's potential for sound entrapment and then contamination of the underlying structures. And you see the reverberation particularly well when there is a fluid-filled structure in the way, gallbladder, urinary bladder, any cysts, and so on. You mentioned needles. Absolutely. They tend to reverberate as well. They trap sound and they actually ring, much like a tuning fork will ring. Yeah.
And this is another good example.
Yes. So reverberation artifact is annoying because it's quite tricky to remove from the image. And this is a nice example where the operator had identified a renal lesion. The lesion appeared solid on the left-sided image, but in fact, it's actually a simple cyst. So how did the user adjust the image, or what did they do? I think the most important thing is to change the angle of approach. If we are scanning the reverberating interface is perpendicular, then it's going to reverberate. However, if we change the angle of approach so that we get away from 90 degrees, then reverberation tends to vanish very, very rapidly. So changing angle of the transducer, both in the scan plane and elevation plane, is probably the best trick. And in terms of abdominal wall causing reverberation, also letting go of the pressure, because tissues will fan out and expand, and you have less tendency to reverberate.
Excellent tip. Thank you, Martin.
Yes, so reverberation can be very large, or it can be very small and focal. In case of comet tail artifacts in the gallbladder, reverberation artifact is just regional because of cholesterol crystals maybe in the wall, or crystals of colloid materials in colloid nodules in the thyroid, or some sort of a stitches or foreign bodies are very, very small. So you're not going to have reverberation over the whole image. It's only going to be very, very narrow. And this special type of reverberation is often described as a comet tail artifact. It's simply reverberation, but over a short distance.
And similar, I sometimes get a bit confused between this ring down artifact and the comet tail artifact. Martin, please tell us the difference.
You know, I think sometimes we're splitting hairs in terms of how we describe it, and sometimes the terminology that comes into common usage is not necessarily the correct terminology, but it's well understood by people. So the artifact you're showing here is probably a set of B lines of a lung ultrasound, and this is sometimes referred to as reverberation or rockets or comet tails, but it's actually ring down artifact. And ring down artifact is distinguished from reverberation in that it goes all the way down the image. It is associated with gas, and it's associated with resonance of a bubble of gas where the sound gets trapped inside a bubble of gas, and the bubble behaves like an elastic ball and continues to emit echoes for a long, long time. So these artifacts in the lung, it's unambiguous. These are B lines, and you know that many B lines are associated with a wet lung. But in the abdomen, for example, ring down can be quite helpful if you find it in liver. You know that there is gas in the biliary tree. So pneumobilia in people who have had a sphincterotomy or similar will create characteristic ring down artifact. And sometimes you have echogenic foci in the liver. It might be all sorts of things. It could be granuloma, it could be a calcification, or it could be gas. So the presence of ring down will tell you that it is definitely gas.
Beautiful. Thank you for that. So these are another few examples, as you have mentioned, that it can be bound gas, pneumobilia, you have mentioned, which is very rare. And abscesses, they can give some, if they produce some gas, they can cause the similar ring down artifacts.
Yes, yes. I remember a patient I scanned recently with Fournier's gangrene, and there was a ring down artifact everywhere due to his infection. Yes, it's a very impressive.
Yeah.
Mm.
Yeah. And some more examples. And one of the things that you have mentioned is that compounding, if the tissue compounding is turned on, then all these artifacts, they change the direction because the ultrasound is going in different directions, isn't it?
Absolutely. And I think this is quite useful actually to know for users of ultrasound, particularly when you're imaging lung, because it's imperative that we turn spatial compounding off when imaging the lung. Otherwise, the spatial compounding makes it very ambiguous as to how many B lines there are in the image. And we can overestimate the degree of interstitial edema by having compounding on. So most of your systems, of course, if they have a lung preset, that lung preset will have the compounding switched off for that very reason. But it could be that in a complex situation where you're imaging a bit of the abdomen, a bit of the heart, you might just grab the same probe and put it on the lung to have a look, not realizing that compounding is still on. It should be turned off.
Thank you. And this is the ring down artifact. It is, we just mentioned earlier. Now, another common type of artifact we find is a mirror image artifact. And in this illustration, I tried to draw it. So this is the structure which is causing the reflection, and this is the real structure, and the machine is assuming that there is an object there. And especially when we do the ultrasound of the diaphragm, for example, liver, we find this type of mirror image artifact a lot.
Absolutely, yeah. And the mirror image artifact, the beauty of it is it's exactly the same as we see in the real world with optical artifacts.
Yes.
So we might have a object in front of a mirror. In this case, it is a focal liver lesion. And then we have a mirror behind that object. And so we are seeing the projection of that object beyond the mirror. In case of a curved mirror, the object will change in size. And, I think most of us have at some point stood in front of curved mirrors, usually at just sort of museums or science exhibits, and they create funny appearances. If you have a mirror that is concave, you will tend to appear broader. If you have a mirror that's convex, you'll appear skinnier. Or if you have an irregular mirror, you can be quite irregular in shape. It's exactly the same with mirror images. So in the case of diaphragm and then the pleura air interface, which is forming a mirror, that was usually going to be a concave interface causing enlargement of the mirrored object.
And you have got some more here, Martin.
Gosh, we do. One of the important things about mirrors is that the mirrored object and the original object might not necessarily always be in the same plane of imaging. So in this case of liver cyst that's projected into what you might think is the lung, it's not actually visible on the top picture. And that's because the mirror works out of plane in this case. The next image, we have a kind of a funny picture of spleen and kidney, and then the kidney in the chest. That, of course, is just mirror image, and actually tells you that there is no fluid in the lung, because if you had fluid there, then you couldn't get this mirror artifact. So it's quite a funny image. But it's actually also diagnostic.
Reassuring.
And of course, other mirrors might be gas in the rectum, for example. So here you have a duplication of the uterus. You might pause and think, gee, are we dealing with a bicornuate uterus or didelphys or something like that? It's simply mirror image artifact. And other things that can cause mirrors are bones or strong fascial interfaces. So here we have a temporal artery being assessed for temporal arteritis, but we see a mirror image inside the patient's head. What's interesting about mirror images, Abhijit, is that if you were to do spectral Doppler sampling and put it into the fictitious vessel, you still get beautiful spectral Doppler sample. Everything is mirrored. B mode, color, and spectral Doppler, and 3D, any part of ultrasound.
Beautiful.
Oh, well, here I am in front of a funny curved mirror. I am skinny, but not this skinny. So this is a definitely convex mirror. And next to my image is a set of bladder images with a pelvic mass underneath it. That pelvic mass is, of course, a mirror image artifact. But you can see in the transverse section in the image on the right that due to the curvature of the mirror, the bladder is now much, much smaller. This artifact has caused many people to be confused as to what this pelvic mass actually is. It's not uncommon. If you look out for it, you'll see a pelvic mass that is actually a mirrored bladder. It's particularly common in children, actually, rather than adults, because their rectum is relatively straight in contour and they have to be beautifully gassy.
Thank you.
And so how do you distinguish, a mirror image from a real object is probably the million-dollar question, because very important we do so. How do we distinguish hepatization pattern of the lung, for example, from a mirror image of the liver? And one of the best words of advice I have is to look beyond and see if you can see real structure. So in this case, you're pointing to the ribs with black arrows and your red marker. If you're seeing ribs, it means that the structure is through transmitting, and this is not a mirror image artifact. This is actually a real hepatization pattern of the lung. It just happens to look exactly the same as the liver. So seeing through the object is key to confirm that this is real, because you cannot see through a mirror. I often tell people, look, it's like looking in your bathroom mirror in the morning. If there's a cockroach on the back of the mirror, you will never know. You cannot see through a mirror.
Excellent. Thank you. And the little more complicated stuff, range ambiguity. And this is one of the thing I really struggle to understand, Martin.
Yeah, so you really have picked a difficult one. This artifact only arises when we are using more than one focal zone. So I'm not sure whether all users have this facility, but certainly on medium or high-end ultrasound machines, you can use multiple transmit focal zones. And in order to save time, the ultrasound machine does not wait for the first beam to reach to the bottom of the image and return before the second beam is emitted. It is because this will take too long. So for example, if you have 3 focal zones, the machine has to use 3 beams to sample each line of sight. It, of course, has to be done in sequence. So the manufacturers tend to cheat a little bit. They send the first beam, which is focused to a shallower focal zone. And then as soon as the echoes are gathered from just that section of the image, another beam is emitted to the second, deeper focal zone. And the assumption is that the first beam is transmitted to a shallower region, it's weaker, and it will peter out, and it will not generate further echoes. And that is true most of the time, but it's not the case when there is a low attenuation, like a fluid-filled structure in the field of view. What happens in that example is that this first beam is emitted, echoes are gathered, but the first beam continues to propagate. The second beam is emitted, the first beam is still propagating and generating echoes, and those are then now returning to the transducer, and the machine assumes that these echoes have come from the second beam, which is the current beam in transmission. And those echoes are then misregistered, which is why this artifact is called range ambiguity. It's a ambiguity as to the depth range of the echo. It produces very bizarre artifacts where there's often miniature versions of the same object, and the real object or real boundary is really the deepest boundary in this case. So you can see probably from a clinical perspective the easiest in ascites, but only when you're using systems with multiple focal zones. And actually, a lot of machines use multiple focal zones to give the user better quality image and have a better lateral resolution at multiple levels of the picture. So you may encounter this. It's very bizarre and disorientating. And if all you do is change the focal zone position, you'll see this artifact just magically disappear, especially if you drop the focal zone down.
Thank you. Now, of course, there may be some issue with the machine, and that can give us some machine artifact as well.
Yes, and it's actually becoming less and less common. The artifact on the left is a stitching artifact where there's a break on the image about 2/3 of the way down. And this is related to use of multiple focal zones and the machine not correctly calculating the attenuation range for each of the beams. It's not very commonly seen. Machines are very well designed nowadays. The more common one that you will see is electrical interference. That is particularly the case with smaller portable machines that don't have a lot of shielding, and that's for reasons of being light. So if you somewhere near something, it generates strong radio frequency sort of interference, like it can be air conditioning unit, it can be near an MRI scanner or something with a high energy. You can see wavy sort of patterns in the image as electrical interference. Of course, if you drop a transducer, unfortunately, or it gets damaged, or simply the elements die, you can have dead elements in the picture, or in the next image, element that is ringing and producing a comet tail artifact artificially, and that's due to malfunctioning element. Or if you have a major malfunction nowadays, you'll see it. When I started in ultrasound, we actually had to calibrate our machines. They were analog, and so you would have to every morning check that your measurements are accurate. You no longer need to do it. Usually when there's a major system fault, you'll see it. It will not be the case that your images are miscalibrated.
One of the things that I notice sometimes, especially the ligaments and tendons, is anisotropy, which is also a type of artifact, Martin.
Absolutely. So anisotropy arises from the fact that the reflectivity is angle dependent, and reflectivity of a structure is always best when the structure is perpendicular to the beam. When the structure is not perpendicular to the beam, the reflectivity is less. And so you're right, in curved tendons, particularly tendon insertions, where the tendon is curving, the tendon becomes progressively darker. And so to basically compensate for that, the user also needs to curve the direction of the transducer and walk through that structure in order to ensure that this is not artifactual. For example, you're diagnosing calf muscle tears or rotator cuff tears and so on. Very, very common.
Another thing is a speed artifact.
So speed artifacts are actually quite hard, and I love collecting artifacts. I don't have many examples of propagation speed artifact. As we know, attenuation speed is about 1,540 meters per second, but that's the average. There is a difference of about 10% between different tissues, and so it could happen that you have two adjacent tissues of different propagation speed with a structure underneath it. That structure will have a step in it due to the beam arrival at that reflector at different times. But it is quite uncommon, and it usually surrounds some large disturbance in propagation speed, for example, a large liver mass, and so on.
And this is one of my favorite one, this twinkling artifact. For example, in the bladder, if there is a stone, and if we put the Doppler, colored Doppler, it shows like this.
Absolutely. I know why it's your favorite, because it actually dramatically improves your ability to diagnose stones, particularly kidney stones, not so much gallstones, to be honest. And that's probably because twinkling artifact arises when the structure is very rough and irregular. And as the beam reflects of the structure, actually the different within the beam, different parts of the beam are reflecting at different times because the structure is highly irregular. This causes phase shift and generates Doppler content that the machine then interprets, of course, as intense color. It's so useful to do this because sometimes you might not be able to determine on B mode whether it's a stone or not. So the twinkling artifact is fantastic for that reason. And twinkling artifact is only associated with rough structures. So kidney stones are generally rough, as opposed to gallstones are more faceted and smoother. They don't tend to twinkle so much, but then they're easier to diagnose.
Yeah, so this is one of the examples that artifact is actually helpful to diagnose the things.
Absolutely, yeah.
So how do the artifacts affect the quality of an interpretation of ultrasound images? We have already talked about it. Most of the artifacts actually are nuisance, but some of them are very helpful. Do you agree with that?
Absolutely. Yes, I totally agree with that. And of course, we have covered some of these useful artifacts. Shadowing, to some degree, acoustic enhancement can be helpful. You've mentioned twinkle artifact. That's very helpful. So I think it's useful to know which artifacts will help, like shadowing with stones, and which artifacts really are a nuisance and need to be eliminated, such as reverberation, and how to do it. So absolutely, I think you really see the quality of the ultrasound images being very different in operators who are mindful of artifacts and mindful of the good use of acoustic windows versus those that don't really pay that much attention. And I think you can then get much better quality diagnostic information out of the patient. In fact, one of the criteria we use, for example, when we assess clinicians in their ultrasound images when they're submitting it for certification and so on, is whether they have managed to achieve artifact-free images.
And Martin, is there any patient factor that can affect the artifacts? You mentioned about the pediatric patients and obese patients. Anything else?
Yes, of course, it's interesting because every person's different. And so you'll find vast differences in attenuation, in reverberation. And sometimes it's very difficult to predict. On occasion, you may have patient who is quite big in body size and you think, I might struggle here. I might have someone attenuating. And in fact, you put the probe down and the images are very clear. So I think it's hard to make generalizations. In general, you're right. Bigger people are harder to scan and are acoustically less favorable, but not always. Sometimes you have a child that's very challenging. You really have to be prepared for anything during clinical ultrasound. Absolutely.
Yeah, and sometimes in pregnant patient, I find it quite challenging as well. But again, as you mentioned, it's very, very difficult to generalize everybody.
Absolutely.
One of my favorite topic is the emerging technologies, Martin. AI, for example. Do you think this is making any impact in this artifact identification?
So far, AI has not really contributed that much in terms of clinical practice. Of course, as a research tool, it's very interesting. And I sometimes do a little bit of consulting work for an AI company that's looking at extracting clinical and diagnostic information from ultrasound images. And the system that I have seen can already identify, for example, with a high degree of confidence, what is a calcification and what is not, based on its acoustic appearance and based on presence of shadowing and other characteristics. So actually AI, I think I'm a human and I'm a proud human, but I'll concede that if I can see it, AI will also see it. And I think AI will eventually see it better because AI doesn't get tired and doesn't get despondent and doesn't get hungry, whereas I do. And so there will definitely be a future role. But to what degree AI will be able to actually remove artifacts from the image or flag it for the operator, that I'm not quite sure yet, because the level of skill and the technical nuances that go into the performance of ultrasound are so complex that the human hand and the human brain right now are far better than anything that AI or robotic ultrasound can really offer. But I am not naive. I know the day is coming when ultrasound will be performed by automated systems, and some rudimentary systems, of course, already exist.
And we briefly talked about, actually, we talked about in quite a lot, and you mentioned about there are different techniques to minimize these different types of artifacts.
Absolutely. Yeah. So, if I was to give one big word of advice to people, is that it's good acoustic window. Good acoustic window is 80% of all the effort that should go into ultrasound. Finding a homogeneously transmitted window that does not generate artifacts is where the money is at. Sometimes we train lots of users of ultrasound, as do you, of course, and you'll have someone junior come in and say, look, you're getting beautiful image, I'm not getting such a good image, what button do I push? And I always remind them, there's no magic button, it's your hand finding a through transmitting window that will get you the best result.
Thank you, Martin. That's a fantastic piece of advice. And as you mentioned, that user factor is a big thing, and we can identify and also we can interpret the artifact as long as we are aware of it. That's the most important thing. And a lot of research is going on this field. Are you aware of any particular research that is helping in the identification or how we deal with the artifacts at all?
Yeah, so not so much research in further characterization of artifacts, because I think many have already been described, but there's not many new emerging. But what is important is that almost every educational institution and, of course, practitioners who educate clinicians in ultrasound have ultrasound artifacts in their curricula, because there is no doubt that awareness of ultrasound artifacts and knowing how to eliminate improves your diagnostic yield that you can get from ultrasound. So there is a lot of effort in education about artifacts. It's part of every curriculum.
Thank you, Martin. That was really good. A few take-home points. I'm sure you will agree with that with regards to the ultrasound artifact, we find that this can give us wrong diagnosis. Similarly, it can give us false negative diagnosis if we miss the objects. And of course, there can be incorrect size when we do the measurements and calculations. So it's very important that we are aware of these ultrasound artifacts, and also we try to minimize them as much as possible. Any final words, Martin?
Well, my final words is just go for it. Find friends who are good at ultrasound, such as you. Find your educators, find the best people, and have them coach you through good ultrasound practice. That's invaluable, because ultimately it is our responsibility to correctly assess patients. And once you know your artifacts and how to operate an ultrasound machine well, the wealth of information is amazing. So all the best to your viewers. Abhijit, all the best to you. It's been a pleasure chatting.
Thank you, Martin. That was fascinating. Really, I loved it. There are so many things you had shared. These are very useful. And for my viewers, Martin has got a book on artifacts, and he has got a lot of presentations as well on this topic. And thank you, everyone, for watching. And if you have any comments, please write down below, and we'll get in touch. Thank you very much, everyone.
It's a pleasure.
Thank you, Martin.